there was a great deal of work done over the past few years by secondary analyses of energy oncology trials, particularly Energy Oncology 0617, which was a trial looking at actually dose-escalated radiotherapy given concurrently with chemo and also with or without a second agent called Cetuximab. That trial was negative and ultimately paradoxical in the sense that the patients who were in the dose-escalated arm of that trial actually fared worse than the patients that were at the standard dose 60 gray. And so the group actually hypothesized that one of the reasons that may have happened is that the group in the dose-escalated radiotherapy arm had excess radiation dose delivered to the immune cells. And by that we basically mean that the radiation dose is delivered to circulating lymphocytes in the blood pool. Okay. And so they actually showed in a secondary analysis of that trial, 0617, that a model that they had developed incorporating the average dose to the heart, the average dose to the lungs, and the average dose to the body, with some more complicated math than that, was actually associated with worse overall survival and local disease control. Now, in the interim, since that trial was conducted, we have a new standard of care for patients with unresectable stage 3 non-small cell lung cancer, and that is consolidative Durvalumab, which is given for a year after concurrent chemoradiation is completed. And so what we wanted to ask in this study is, what is the prognostic significance of the estimated dose to the immune cells, termed EDIC, in these patients now that they're also getting immunotherapy afterwards? And what we found is that there remains a really strong association between overall survival, progression-free survival, local control, and actually time to brain metastasis in these patients. So those patients with a higher EDIC, which again is a combination, it's a model of mean heart dose, mean lung dose, and the average dose to the body. Those that received a higher estimated dose to the immune cells had shorter overall survival, shorter progression-free survival, worse local regional disease control, and a shorter time to brain metastasis. The implication of this work really is that there are a number of ways that we can think about reducing the dose to the immune cells, and those can be radiotherapy, optimization techniques. Alternatively, there are some ideas using knowledge-based planning to reduce EDIC, or again, the estimated dose to the immune cells. Proton therapy or flash radiotherapy are all also on the horizon.